Welcome to Shiv Shastri's podcasts. It was past 10 p.m. when I received an urgent call from the hospital to see somebody who had been involved in a road traffic accident. I had finished my dinner and was preparing to get to bed as I am an early riser. I quickly changed and rushed to hospital. He was a young man in his 20s. He had been involved in a hit and run accident. He was conscious and grunting with pain. His pulse was barely felt, his heart racing, and his blood pressure was dangerously low. His belly was tense and swollen. An emergency ultrasound scan showed that his entire abdomen, doctor's jargon for belly, was full of what appeared to be blood. The emergency room doctor had already asked for several bottles of blood to be prepared for the man. Something was bleeding inside his belly, and he would die of blood loss very soon. I had to go in and stop the bleeding. Quickly, I performed the usual tasks that needed to be done. I explained the situation to his relatives and obtained consent. I called for the operation theatre to be readied and the anesthesiologist on call and had the patient wheeled into the operating theatre. For a surgeon, the presence of a competent anesthesiologist is a blessing. An anesthesiologist is a person who keeps the patient alive and free from pain while the surgeon does his job. I would trust my anesthesiologist with my life. He arrived and took charge, put the patient under anesthesia, and nodded at me to go ahead. I had, in the meantime, completed my ritual of cleaning the area to be operated with an antiseptic liquid and covered up unclean areas with sterile sheets. The blindingly bright operating theatre lights reflecting off the patient's abdomen made me squint, but this would change once I started the operation. I cut through the layers of the belly quickly. This was familiar territory for me. It was home. It was what I had trained for. It was what I lived for. As soon as his abdomen was opened, a torrent of blood rushed out along with huge clots. As I used a suction pipe to suck out the blood, the drain bottle that the blood went into soon became full. I rummaged between the intestines to seek the source of bleeding. It was coming from somewhere in the upper part, but I could see nothing. It was blood, blood, blood everywhere, and it was pouring out. I stuck my hand in, deep inside the abdomen, feeling for the liver. One normally expects to feel a smooth, firm dome of the liver, but here I felt ragged tears. My fingers could feel multiple deep gashes in the liver, and it was leaking the life blood out of the patient. At least I now knew where all that blood was coming from. The liver is a unique organ. It receives a humongous amount of blood from two different sources, and all that blood drains into one of the two main veins of the body, the vena cava. The vena cava is a suggestive name. It is a vein, and it's like a cave. And if it is allowed to bleed, it really knows how to bleed and can teach anyone the meaning of bleeding. And here this man's liver was pulped with ragged tears. After 6 or 7 bottles of blood, the man's blood pressure was still critically low, barely recordable. I had to do something and I had to do it soon. My mind went back over a decade to my operative surgery textbook and what my teachers had taught me. The book spoke of a 19th century French surgeon who would remove deceased kidneys in record time in an era when anesthesia was not safe. He would simply cut the large blood vessels and remove the kidney and control the bleeding by packing the kidney cavity with sterile cloth pads. He would ask his assistant to hold the pads in place, keeping the bleeding in check, while he would go out for 10 minutes and have a cup of tea. By the time he returned, the body's natural clotting mechanisms would have reduced the bleeding to a trickle, at which point he would complete the operation. I was not in 19th century France, nor did I have a trained surgical assistant. I did the next best thing. I stopped the bleeding like the French surgeon, using 11 carefully counted sterile packs, and waited for the anesthesiologist to stabilize the condition of the patient. Asking my assisting nurse to press on the packs I had placed, I stepped out to explain the situation to anxious relatives outside. I then returned and closed the belly, leaving the linen packs inside. This is standard practice in some situations. The idea is to get the patient stable in an intensive care unit or ICU and then look inside again with the patient under anesthesia after 24 or 48 hours to deal with whatever needs to be done with other assistant surgeons as appropriate. The man was shifted to the ICU. A day later, I brought him back to the operating theatre and reopened his abdomen. This was just a matter of removing the stitches I had placed a day earlier. This time, I had a team of other specialists with me to deal with the liver or vena cava as required. Slowly, gingerly, I removed the 11 packs, counting the number allowed one by one. I removed 10. The last one was sitting stuck to the liver with all those cuts and gashes on it. I took a deep breath, said a silent prayer, and gently pulled out the last pack, millimeter by millimeter. To our intense relief, there was not a drop of blood visible. Mother Nature had sealed the wounds in the time we gave her. After checking that everything was all right, I sewed up the patient and sent him back to ICU. He recovered and went home. Surgery is exciting but can be intensely stressful.